We're going to start on end tidal because it is the most hyper-specific part, and then with whatever time we have left, we will review all of the pathological conditions that happen in Chapter 17. But essentially, if I was preparing for my own test, Test 2 covering 11 and 17, my brain would be thinking, okay, I have to be sure of all of the things I learned in EMT class. That means asthma, bronchiolitis, pneumonia, TB, all respiratory conditions are fair game for question. Now they get stacked on with the possibility of acidosis, AEMT treatments, AEMT interventions, and end tidal. So what that means is if you're like, dude, I know what asthma is, what's the big deal? I'm like, okay, but do you know it from an AEMT perspective? Do you know what it's gonna look like on end tidal? Do you know what kind of pH it might cause? Do you know what treatments you might do that an EMT couldn't? So you have to be asking yourself those questions. So the best way to probably prepare for the majority of stuff that is on that test is just a Rolodex of conditions. You go to the back of Chapter 17, look for every possible respiratory medical condition, you write it on the left. Then to the right of that, you write down the anatomical structure that it's involved in. Then you write down all the generic symptoms you can think of, dyspnea, dizziness, whatever, and then a couple of symptoms that are hyper-specific to that condition. That's probably the best way through it. Since so much of that is rote memorization, that's why we're putting it on the back end of lecture. End tidal is its own animal, and I think I can save you a lot of time going through it. Now, end tidal essentially, moving through in the AEMT, my expectations for scenarios and practicals in most cases are that you do all of your new toys each time, but not at the cost of patient care. Yes, I expect you to do an IV on every mannequin in every scenario. Not at the cost of patient care though. If my guy's hypoxic and you're so busy starting a line, that's not great, right? It would be better that you didn't get the 2 points that you would get on a practical for doing an IV that you're not gonna do anything with than it would be delaying ventilation. So if you get scared out there, you go back to what you already know. Air goes round and round. Will that be blood? Uh-oh, maybe I'm in trouble. I guess it all kind of goes round and round and in and out. Not blood so much, I'm still learning too. In any event, we can put end tidal on in a myriad of ways, and we should do that each time. This is of course an orange or pink or coral, I don't know. Essentially is our inline to be done between our advanced airways and our BVM. And then of course we've got other ones that'll be like our nasal capnography with either the fin to catch it or not. Now, you would not believe the amount of times I see some poor paramedic that can't get a good capnography, not really sure about what's going on, and all I did is just go over there and just push that little paddle down a little bit, and then suddenly the end tidal looks great. I mean, this is designed largely to catch here, this paddle on the right, designed to catch a breath and then channel that back up essentially to detect the CO2. There are even times where I'll have something without the paddle like this, and then I'll just put a non-rebreather mask over the top, right? To just kind of let that stuff collect. And as much as anybody would say, well, yeah, but isn't it collecting too much? I'm like, well, it's collecting at the same ratio that he expired it at, so it works. So if you're not getting an end tidal you like, just make sure that it's essentially working. There's actually a decent amount of airway stuff that is just the same as every IT conundrum in the world. It's like, is the machine on? Is it plugged in? Have you used the disk drive as a coaster? Like, it's all kind of the same thing. All right. Anybody watch Loki? It's like huge Loki vibes off that. CO2 is the exhaust of metabolism. Your book, does anybody know what your book describes it as? It's so romantic. The smoke of metabolism. That's what I saw. Whoa, excuse me. Excuse me, Nancy Caroline, trying to go steady with me. Of course, we don't use that book. So essentially, just like I said before, if a combustion engine is operating forward momentum in large part with air intake and, well, I mean, we can just say oxygen, because it's using oxygen primarily as well, and fuel, so too cellular respiration, cellular metabolism is using glucose and O2 to make our CO2. And it's the core mechanism of what we're talking about here. Yes, you have to have oxygenation so that way you can have metabolism. Well, once that happens, we need to be able to transport that, i.e. perfusion and respiration. And then lastly, exhalation, which is going to be, of course, blowing out our CO2, which is what we're talking about today. But Ventilation, of course, also requires inhalation, or is beneficial with inhalation. But this is just the process every step of the way, right? This is, what type of respiration is exhalation?
External.
External, sure, right? It's between the lungs and the blood, whether in or out. Very good. And you'll see a lot of things on here. I think almost all the fundamental terms for ventilation and respiration and just breathing is what I should say appear on here. Oxygenation, respiration, ventilation, perfusion, metabolism. These are all the fancy words, right? What does oxygenation refer to specifically?
Cellular metabolism of O2.
Close, closer, warm. Yeah, that's what he said. I think it's the hemoglobin. Oxygenation specifically because you know if you don't breathe, you die, right? Why? Well, because you're not getting oxygen, and because that oxygen isn't in the blood, and because that oxygen in the blood isn't getting to the cell, and that cell isn't metabolizing, right? That's the long answer. You also know that even if you're breathing, you can die. Why? Well, because maybe you've got a perfusion issue, right? We've got ventilation is okay, respiration is okay, but perfusion is bad. But you can have okay ventilation and okay perfusion and still die.
Respiration problem?
Maybe it's a respiration problem, absolutely. So even though you're getting gas into the lungs, they're not crossing across the alveolar wall. Let's say that they could. What I'm getting at essentially is we know ventilation, perfusion are two big hitters. Respiration is another one. What kind of patient has an issue with oxygenation? Carbon monoxide. Very good. You can even have an issue with, and you can, look, aren't you in luck? There's a million ways to die, don't even fit on this slide, right? Because you can have an issue. What is the compound or chemical that is going to have essentially no effect on respiration, perfusion, and arguably not even oxygenation, but will still kill you because you can't metabolize? It's a gas.
Cyanide?
It's cyanide. Because cyanide won't affect your ventilation initially, your perfusion, or your respiration, and doesn't even specifically affect your oxygenation, meaning it doesn't in any way affect how the oxygen is binding to the hemoglobin. However, it will stand in the cell between the mitochondria and say, no O2, not today. Was it so many ways to die? So EtCO2 is a tailpipe to exhaust. No fuel, no smoke. No pipe flow, no smoke. No exhaust fan, no smoke, right? I couldn't get away from the smoke, so cute. Now we touched on this a little bit in 11. Make sure that you know that I'm using this as a launching pad to the quantitative effects of end-tidal. This is, colorimetric is qualitative. Like, colorimetric devices are just essentially, despite the numbers, I guess, on the side, are just saying CO2, right? Remember the cootie catchers? Right? Do you like me? Yes or no? That's a colorimetric device. Is there CO2? Yes or no?
Are you seeing this on the field?
Yeah, absolutely. Yeah, earlier on, admittedly, but definitely. What sucks is you got a time that you need it, and then you pull it out, and it's already the wrong color. You're like, oh, well, great. Oh, no. Just breathe across it. So this is essentially, colorimetric devices, much like those dead space bulbs, are largely just saying, like, is something present, yes or no? That's a qualitative effect. Even if you didn't grow up in the 90s, like I did. Well, I guess I grew up in the, what did we grow up? 80s? 80s, right? We're 90s kids. That's when we became people. Because you're 84? Mm-hmm. Yeah. Blood type O?
No, I'm not anymore. I thought you were 20.
Oh, I'm not. I thought you were 40. Oh, so all these times I keep saying you're 40 and you've been like, I'm not. I'm like, okay, Sam. All right. 91? How old are you then? What's the math? Holy sh!
You're thinking of Steven.
I must be. This entire time I thought we were born in the same year. Why does he look like a man then? And all right. Barney's bad, Big Bird's good. Let's keep moving. I'm so sorry, Sam. I get 40. It's like 6 more years.
I need some time to process that.
I don't know, dude. 404 is a stretch. That's a while away. I mean, just, yeah, I mean, it might be far from where you are. send me a text in
Okay, dinosaur.
20 years. Yeah. All right. Capnometry is the number. Capnography is the waveform. I don't super care that you know that, but it does cause like a twitch in my eye sometimes on the truck when somebody's like, what's a capnometry? It looks like bronchospasm, and I'm like, well, that's okay. I know what you mean. That's okay. Normal range is, of course, 35 to 45, which is the same for all ages. That only changes when we essentially have a chronic experience of trapped air, specifically trapped CO2. So their new normal becomes 45 to 55. So be careful there. I guess what I mean to say is you might get patients that are having a problem that present with an end tidal of 46, and you're like, oh man. I'm like, well, he's got emphysema. That is his normal. Also, listen to me when I say that you need to be very careful about your scenarios. It happens to the AEMTs when you get capnography, and it happens to the medics when you get EKGs. Don't get so hyper-focused on this. I do think there's a ton to say and a ton of benefit from learning end tidal and what it means. But if you spent the majority of your time here just being like, I just use end tidal to make sure it's bronchospasm, I'm like, okay, that is probably better than the endless amount of times people are like, okay, well, hypercapnic, and then if he retains, and then there's that trapping or whatever, I'm like, yo, he is bleeding to death. Will you please put your hand on that wound, you know? So don't get so hyper-focused on the possibilities and meanings of this. We'll talk later about what the two most common, okay, I feel so bad, the two most common assumptions to be made about end tidal. Us 80s kids. Oh dear. I just meant you look old. That's all I meant. You know, I had that experience. I was standing in line at a grocery store, and there's this woman standing next to me, and she was like, oh, we need orange juice. Hey, will you go get the orange juice? And her kid ran off down the thing. So I just said, I was like, isn't it awesome when they start working for you? Like, you get to this like curve there where they actually start contributing. And she was like, yeah, totally. That's my sister though. And I was like, oh, I'm so sorry. You just look old. Like, I didn't say that last part, but I thought it. In any event, clinical uses of EtCO2, it implies efficacy of ventilation and perfusion. This is probably the last time or the last place you will hear it this way. What you will hear everywhere is EtCO2 equals perfusion, and that's not quite right. That would be like saying SpO2 equals oxygenation or something, or 100% SpO2 equals oxygenation, and that's not true, right? What would make that untrue? Carbon monoxide, yeah, that would probably drive it down. If I wrote 100 on the outside of it, like in any event, it's not, most of this stuff implies it. Like until we can do arterial blood gases or put them through a lab, you know, a lot of it is implied. And end tidal is no different. Now, end tidal is awesome, but I guarantee that you're gonna hear out there, well, end tidal is perfusion, and it implies it. What's most important to know first is that it's not just perfusion, it's also ventilation. Meaning, end tidal, no trick here, end tidal is measuring what?
Millimeters of mercury.
That's how it's measured, but what is it measuring? It's measuring carbon dioxide. So if I'm gonna get a measurement of carbon dioxide, again, no trick here, what must you have in you? Carbon dioxide, right? How do we get carbon dioxide? Well, through cellular metabolism. But the question becomes, that's how I get it in the cell. How do I get it out of my body? That's the ventilation part. So you can have an issue in either case. So it implies these things. It's not as perfect as I think some people say. Now, put simply, what we will often, it's the gold standard for a lot of things. In fact, you ever seen a nasal intubation? Yeah, the idea is, I've only done two. They're not, I don't know, very popular, but it's when you get people that have lockjaw or trauma you can't do a oral intubation. You just essentially, it's actually pretty anticlimactic, but it's super cool, I guess, is you'll just take the end tidal, and as you're waiting to intubate the patient, not end tidal, the ET tube, you just curl it up in your hand like this, so it gets this gnarly hook to it, essentially. And then, not a lot to say, you put them in the sniffing position, and then you push it through their nasopharynx, essentially all the way down there. Sometimes you got to twist it to get past the glottis or whatever, and as soon as it fills with condensation, you know you're basically in the right spot. I'll never forget, essentially, putting a nasal intubation in and forgetting to put end tidal on. Earlier in my career, I just forgot. Thing was full of condensation. Condensation doesn't come from the stomach, so I was like, we good. Heart rate got fixed, everything was okay. I walked in, and the doctor said, what the hell is that? I said, it's an intubation. He said, why is it in its nose? I said, because it all goes to the same place, doc. He said, well, what's his end tidal? I said, I don't know, I didn't put it on there. And he was like, oh, okay. And then he just deflated it and ripped it out. Now, the joke's on him, because he struggled to intubate him, of course, and that was a very successful thing, but I'll never forget that impulse. I'd always kind of heard the end tidal was the gold standard for intubation, to the point where, like, if you don't get an end tidal reading, then you haven't intubated. Let me encourage you much the same. I was never super good. Well, I shouldn't say never. I guess I got good at it, but I didn't start very good at IVs, unlike Pam. But I started very good at intubation. And I think it was just simply because my paramedic teacher said, if you don't see that tube pass through the vocal cords, then you didn't intubate. Simple as that. And so, you know, anytime I couldn't see the vocal cords, I would just think, well, it's not good, and I would pull it. And end tidal needs to be our standard for that. Now, we don't intubate, but we should be putting it on iGels or Kings or combi tubes. If you put it on an LMA or a King LT, and your end tidal is 0, something is very, very wrong. And it probably means that you're not in the right place. Yeah.
So you're just using it to verify that you're in the right spot?
Are you implying that's the only thing we're using it for?
No, but like for innovation specifically, like it's the gold standard because you're verifying that you have it incorrectly, or have it like in correctly?
Yes.
Okay.
You won't get an end tidal reading unless a series of things are happening. You won't get an end tidal unless you are getting gas that is being ventilated from their airway. If you're in the stomach, you will get a 0. You'll get a 2 to 6 for like a couple of breaths, and then you'll stay at 0 because gas is not getting exchanged in the stomach. So it's the gold standard for iGels, gold standard for all airway. It's a gold standard essentially for saying, hey, I think ventilation and perfusion is working because I can see the end tidal. So that's why we're going to put it on every patient in student world. It's also super good for CPR efficacy. That's a registry question all day. And I know that because it's an AHA question, if you remember from BLS. Well, maybe you wouldn't. That might be an ACLS now that I think about it. But the point is this: if you put somebody on end tidal who's in cardiac arrest and they're hovering around 20 millimeters of mercury, and you notice essentially that it's 18 and 16 and 15 and it's just staying low, the answer to the question is verify your compressions. Because, or you tell me, I guess, why would poor compression lead to hypocapnia? Low perfusion, right? I'm not squeezing the blood around, not moving it. So it can't get to the lungs and it can't get ventilated. Sudden spike in ROSC. There's another super good thing. It's the reason why I teach you to check only one pulse as an AEMT. If you were my medics, I would be teaching you to do it for there as well. I'd say, look, the only reason why I'm even checking a pulse in the first place is whether or not to initiate the AED or CPR. After that, who cares? Because in what world does a guy have a sudden spike of, get a return of spontaneous circulation, but doesn't have a spike in end tidal? No way. Don't bother checking a pulse. So you'll hear essentially, if you must know, the answer is every 2 minutes is when you check a pulse, but I'm not going to ask you that question. I'm going to say, keep doing compressions until they ask you to stop, or you see a spike in end tidal. It's also good for cessation, meaning that, put pretty simply, if a person never got above 10 millimeters of mercury for longer than 20 minutes, the likelihood they come back is essentially 0. It is statistically not possible. Yet here's the issue with that. Most people are like, oh, his end tidal went from 30 to 10. He's not coming back. I'm like, no. 2 things. It's a decent predictor that they will not likely come back, but it isn't a reason to stop specifically.
It's a combination of stuff. Like it's a witness arrest.
Yeah.
That it's not just like entitled. But
Yeah,
it's really
but that's usually what happens is people will view the end title and say, oh, well, that's it. Basically, a study was done and said, oh, okay, I'm going to check here. What are the likelihood that somebody survives if their end title A, never got above 10, and B, never got above 10 within 20 minutes? If that never happened, it's statistically impossible for them to ever come back to life. The implication there is sometimes people are like, oops, it dropped below 10, they're not coming back. And I'm like,
Oh, okay. The difference between like how.
if they ever got above 10 or not is the big thing. Now, I am okay with you saying, look, I'm going to just call this right here. I've got a guy who's been at 10 for 20 minutes. I'm like, cool, call it.
Question.
Yeah.
As on the scenarios, if we get cardiac arrest, we will, I guess.
Yeah.
You said we don't transport until we get.
Yeah. Put simply, don't transport people who are in cardiac arrest.
Alright.
We'll get into it more probably Thursday, but put simply, just work them right there.
And as a ACE, we still call for. Can we call for med control to call for that time, or we?
You can. Yeah, you'll need to talk to a doctor for time of death specifically.
Yeah.
But it depends on the protocols, because in like the companies I worked for in Michigan or whatever, you wouldn't even call a doctor for cessation orders. You just stopped because they're dead. But ultimately, somebody's got to sign the certificate.
We've talked about it. What does cessation mean?
Stopping.
Stopping? Okay.
You know, you already know some of this. If you walk up and a guy has no head, you're going to stop before you start. Like, what does it matter? He's got no head. Put simply, if a guy's end tidal never gets above 10 in a cardiac arrest, it is like he's decapitated. His cells have stopped metabolizing and they will never work again.
Less than 10.
Less than 10 for 20 minutes. So this is what most people think of. Most people will go their entire careers only thinking these two things with end tidal, and they will be okay almost always, which means that if you must retain the barest minimum of information, it's this right here. That generally speaking, high CO2 is hypoventilation. You don't breathe, your CO2 builds up, so every breath you take is a lot of CO2. What 80% of the time people are using it for is a sign of poor perfusion. What this means is I got a guy that's pale and dizzy. He says, should I even go to the hospital? I say, well, I don't know. I'm not pale and dizzy. That's why I'm not going. But you are pale and dizzy. So yeah, I think you should go. And he's like, well, I don't know. Maybe it's just allergies. And I'm like, I don't think that makes you pale or dizzy. And he's like, well, the fireman said my blood pressure is fine and my heart rate's fine and my SpO2 is fine. I'm like, well, that's all true. Look, let me put you on end tidal real quick. Just see what that says. This is your measure of your CO2 instead. And his end tidal comes back as 31. What did I just learn?
He's hypocapnic.
It is implying poor perfusion. That is a sign of hypocapnia. What might that mean? But why would a guy be pale, dizzy, and
I mean, his blood's basic, so.
his blood is basic? It'll take me a second to get there. Oh, because well, we don't know that, but I see where you're going. Shock. I think he's in shock. In EMT world, would you have thought he was in shock? You better, because he was pale and dizzy, right? Now you've got a vital sign to essentially prove it, right? You're like, no, buddy, something's happening in there. You definitely need to go, right? So most people will just say end tidal is a sign of perfusion, and it kind of is. It implies perfusion, but it's not always. Here's an example, right? In DKA. In DKA, you've got a guy are people in DKA ventilating just fine? Are people in DKA, let's just say, largely perfusing just fine? They are. I mean, they don't have a pipe problem, they don't have a fluid problem, they don't have a pump problem. They're perfusing just fine, yet all the same, their CO2 might be low. Kind of in the inverse, right? In a certain sense. Like, we don't want to look at a guy in DKA and see his end tidal at 32 and be like, oh, snap, he's not perfusing. Like, no, he's just acidic and he's breathing off too much CO2. That's why. Put end tidal on the end of things. We can save us some time there. So with high CO2, again, this is an asterisk here, right? All things trend towards zero. What I'm talking about is timeline stuff here. Like if I said, is hypotension a late sign in poor perfusion? Yes, it is. Could you have hypotension immediately?
Sure.
Absolutely you could. So the late sign might happen very early. You with me? Yeah. Right. And so hypoventilation can lead to high end tidal. The question is like, what's your timeline like though, right? What's your time? Like, do you have a partially obstructed airway that is somehow leading to a high end tidal? Or do you have a completely one and then you go from high EtCO2 to low CO2 in the blink of an eye? But in general, hypoventilation. That means your guy ODs on some opiates, and before you ventilate and give him Narcan, his CO2 is just building up and up and up. It's why once we start ventilating him, we might see a high end tidal because he's got a lot in him. Now, like I stressed, and we'll do quickly here, it's set on a timeline, right? A guy essentially, a guy has a foreign body airway obstruction rather, so he stops ventilating, but his PaCO2, or his, the EtCO2 in his blood, let's say, his CO2 in his blood, I should say, is going up. Do you know now, Sabina, why? Why is a guy who's not breathing still getting an increase in CO2? Because he's not perfusing. I don't know. I don't think so. It stacks back to, why is there CO2 at all? That's true, but that's with our ventilation. Pam, why would a guy who's not ventilating, why would his CO2 go up? He's still metabolizing. What is he using in that metabolic process to get CO2? Sugar and, Alanis? Oxygen. Now he will drop eventually, right? Like you were mentioning, the perfusion issue starts to happen. What I guess I mean is there's more process than negative perfusion happening here. Think of it like this. I need O2 and sugar to have cellular metabolism, to have CO2 and energy as byproduct, essentially. On a long enough timeline of hypoventilation, my oxygen will decrease to 0, and then my end tidal will drop regardless of what perfusion is happening, because I don't have oxygen anymore, which means I can't metabolize. In addition to that, we are also going to start to have a problem with perfusion, because as we are hypoventilating or hypoventilatory, our cells will start to die. So now we have hypoventilation and a lack of perfusion, as now our cells start to die, they can't transport it, and we have all kinds of other processes happening. We have a buildup of lactic acid due to an anaerobic metabolism. As that buildup of acid changes our pH, we start to experience a rightward shift. So now we are just stacking problems. First, we weren't ventilating. Then we started to have our oxygen decrease. Then we were experiencing perfusion issues. Then we were experiencing rightward shift in the hemoglobin dissociation curve. Now we're experiencing a lack of binding and appropriate oxygenation. And buddy, these blocks are stacking faster and faster and faster, right? So in cardiac arrest, we care about using CO2 as a marker of perfusion. This is kind of to try to help kind of correct the idea that I think what happens a lot early on in A class is essentially we're like, whoa, this guy is acidotic because he's in cardiac arrest, and that is essentially true. So we need to get that CO2 out because we want him to balance his pH. And that is true, but he's going to stay acidic despite our CO2. because he is experiencing lactic acid creation through a anaerobic metabolism. Even though you're getting the CO2 out, he's still largely experiencing inefficient metabolism, so his lactic acid is building up, meaning even if I could get all the CO2 out of him, he's probably still acidotic because it's building up in his system otherwise.
Where does sodium bicarb come in all this?
So do you mean bicarb as the buffer?
Yeah.
Okay, 'cause sodium bicarb will be a little different, but bicarb, HCO3 rather, bicarb comes into play as a buffer and a balance to this. And where it would come in is, put pretty simply, your body is ordinarily going to be excreting fluid, urine, and with that will go unneeded bicarb. Your kidneys will say, actually, I'm super acidic due to lactic acidosis or hypercapnia. So I'm going to go ahead and help balance this system and start reabsorbing this bicarb instead of just excreting it. And as bicarb slowly builds over the next day or two, it will help balance the equation. So the kidneys are great for a slow-moving boulder, essentially, to help balance by reabsorbing the bicarb. But what will happen much faster in a more healthy situation is you will start hyperventilating, because breathing off the CO2 is going to have a much faster immediate effect on your pH than the slow metabolic process of reabsorbing bicarb. So in short, your breathing rate will speed up to get out the CO2, which is going to shift your scale faster, because it's going to take a day or so for your kidneys to reabsorb the buffers. As much as hypoventilation causes increase in end tidal, this is the way I always kind of looked at it, right? Actually, so you take a Coca-Cola can, right? It's got CO2 in it, right? If I pour that can out faster and faster and faster, is there more CO2 in the can or less? Less. I've got a can of Coke. It's full with, engine degreaser and CO2, right? If I pour out a little bit of Coca-Cola, is there less CO2 in the can? Which means every pour, less CO2, right? Every pour, if I strapped an end tidal to the end of that Coca-Cola, every time I poured, the end tidal would go down. Why? Because I'm pouring out the carbon dioxide. You are the Coke can. Or if you're born north of the Mason-Dixon line, perhaps you're a Pepsi can. But in any event, the more you breathe, the lower your CO2 will be.
Or a pop can.
Big poppin', baby. What's worth noting is that it's not just respiratory, though that is one of the major governing dramatic effects. Also, hypermetabolic states will cause, right? Like, we didn't talk about it much on the previous slide, but if your thyroid is your primary gland for metabolizing and you've got too much of it going on, your CO2 production will go through the roof because you're in a hypermetabolic state. And so we talk a lot about the airway, and I think it's important because most of the cases are going to involve that, but it can also be a metabolic state shifting our CO2 as well. Why would a person in cardiac arrest have low end tidal?
No ventilation.
Rose?
Is it in the wrong place?
That's a great answer. I love that. I wish I'd have thought of that. Yeah, sure. Maybe you've attached it to his rear end. Yeah, sure. It's gonna monitor methane from that point. Ultimately, what I'm getting at here is that, is it possible that a person in cardiac arrest that we see a slight increase in end tidal? That's right, on a long enough timeline, right? They all trend towards zero. I think these lines get crossed because we talk about them in the same day or two, but alkalosis and end tidal do have some associations, but, well, how do I want to phrase that? I think at this point, I'm like, okay, we can have a conversation about acid base and about how it makes oxygenation harder, but that's kind of a niche and isolated conversation. Now we just want to talk about the end tidal and all the respiratory effects that can result from that. which are, so if we go through this and you're largely thinking, ooh, are they acidic or alkalotic? I'm like, okay, that's extra credit thinking, but probably isn't where we need to focus just yet. Meaning, if a person is having an asthma attack, it might be cool to know about their pH level based on their presentation, but it's not relevant almost in any way other than it makes them worse. What I don't want is somebody to be like, oh man, okay, this guy with wheezing is hyperventilating, but he's also got trapped air. If his end tidal is 23, and then I put him on the da-da-da, I'm like, right. But in the meantime, the EMT's giving him a bronchodilator and saving his life. You see what I'm saying? So don't, like, something about a forest and trees and then, like, tripping on dollars and then, like, all that. Birds in two bushes. I have no bird. I have no bush. In shock specifically, right, let's take hemorrhagic shock. Your perfusion is going to drop. Your blood will slow, and that's going to slow the delivery of O2. Because your cells are getting less oxygen, they are moving from aerobic to anaerobic. Anti-aerobic. Which means, now I don't care that you know anything about pyruvate really specifically, it's just instead of oxygen and glucose, it's something else. And the byproduct of that pyruvate in large part is an acid, which is not occurring when we are in aerobic metabolism. The point here is that lactic acid is created in anaerobic metabolism, but CO2 is not. So essentially, if we go back to our timeline, why would we see a PA CO2, partial pressure in the arteries of carbon dioxide, go up when a person goes in cardiac arrest? Well, because they have circulating oxygen, they have circulating glucose, and therefore they're still metabolizing aerobic metabolism. And then about 6 or so minutes go by, they haven't been able to move any oxygen or air in and out of their body, which means now they're in anaerobic metabolism, which means they're binding glucose not with oxygen, but with pyruvate to make lactic acid. Before they were making essentially energy, water, and CO2. Now they're making energy, very low amounts of energy, and lactic acid. Anaerobic metabolism will not increase your CO2 is the summary. Now, like I said, EtCO2 implies perfusion. It's not measuring it specifically. If you have a patient in septic shock with an end tidal of 38, you might be like, oh, okay, we're okay. That's good perfusion. If you thought end tidal was just only the marker for, you would look at a 38 and be like, oh, thank God we can do end tidal, and know that this guy is perfusing just fine. Because he has a widespread inflammatory response, his body is in a hypermetabolic state. Or if you want to back up and put a finer point on it, they're hot to the touch, they're febrile. That means their body's working hard. You with me? If I got a guy that's having a fever, what would I expect about his end tidal? I would expect it to be high. It may not be based on his situation, but I would at least expect him to be metabolizing quickly. Why would a person with a fever be metabolizing more than when he didn't have a fever? Because he's trying to fight the infection. He's working harder. Excellent, right? But does this end tidal imply, shouldn't that be higher? It should. That's a normal end tidal at 38. And if he's in a hypermetabolic state, it should be 48. Why isn't a guy in septic shock? Oh, you beat me right to it. Let me finish it essentially just in case. Why would a guy who is hypermetabolic, creating large amounts of CO2 and septic shock still be hypoperfusing?
Because he had already had a super high end tidal.
And he's on his way down?
Phase, and he's already...
Okay, I can appreciate that. There's a simpler answer, but I like where you went with that. Aiden? Further along in the timeline, which was kind of like what he was saying, essentially. Alex? Hot dang. Sorry, kids at home. Because he's decompensating. What is his vasculature doing in septic shock? What's his blood pressure right now? Low. So even though he's creating a bunch of CO2, he's got widespread vasodilation, and he's got poor perfusion.
Get home with the over-ear audio technique.
Yeah.
Go to fight or flight.
I put a gate on it, so it'll just, you'll hear me be like, yeah.
Yeah.
Would
hypo or hyperthyroidism, do they still stay in the normal 35 to 45 range?
I would expect it to be higher. So part of the issue with hyperthyroidism is kind of you can have asthma and be breathing just fine. Why? Well, because asthma is a chronic condition that kind of comes and peeks its head when it wants. Okay, hyperthyroidism is similar. I got hypothyroidism. I'm like, you need to go to the hospital. He's like, nah, I'm good, dude. I take medicine or whatever, but maybe I have an acute attack or disorder, then you're going to see this hypermetabolic state and a higher end tidal and so on and so forth.
There's something that bodybuilders, there's like, you get used to it, so the normal now is like higher.
That happens with COPD for sure, because they're retaining CO2. I'm not sure that that occurs with hyperthyroidism, and it's probably because they maybe don't retain as high a level or as a consistent of a level, but definitely COPD.
So what exactly is like hypothyroidism? It's just like, it's their metabolism, right?
Yeah, simply because it's a long conversation and we've got a day on it, I'll put a pin in that. But suffice it to say that if I squeeze your adrenal, there are a couple different conditions that can cause it. If I squeeze your adrenal gland, too much of your adrenal hormone comes out. Well, one of those hormones is epi, which means if I squeeze your adrenal gland, epi comes out and your heart rate goes up. In hyperthyroidism, there is a series of different possibilities where too much thyroid stuff is happening. So your thyroid, instead of sending the message of a normal metabolic process, is like, just kidding, twice that, please. I'm like, okay, well then you start metabolizing a lot. Take a quick break. All right. So as a fundamental intro to end tidal, of course, we have our pleth wave at the top here. This is pulse oximetry. Pulse oximetry is measuring the amount of oxygen contained generally on your inspiration. So as the pleth wave moves up, that's your inhalation, and as it moves down, that's your exhalation, but it's the exact opposite for end tidal, right? In end tidal, your exhalation is going to be the incline, right? Because it's measuring the amount you're exhaling. It should also be noted, I don't have a slide on here, but these waves are measured chronologically from left to right, and it's always a bit arbitrary. Like, you could say, I mean, we can't see this number. Well, I guess we can see over there, that's 36. So we can tell because of the capnometry that this is an appropriate amplitude, meaning up and down, right? 36 is healthy, we're okay with that. And I suppose we could technically tell the rest, that's probably the respiratory rate is 14. But we have to be careful, because if I just showed you these two pictures and then, just the two in the middle near the red arrow here and said, what is this? You would have no reference point. Like, unless you had a gauge here that said 60 is probably what that says, or a 35, these are just arbitrary waves, and there could be arbitrary rates. If this guy doubled his respiratory rate, we would see more of these closer together. If he slowed his respiratory rate, we would see less of them and farther apart. Now we're going to move quickly through this, and don't overanalyze the plateaus or the points here. I think I do have one question on the test that's like, what would you see in a D point? I'm changing the language of that, right? So I don't expect you to in any way memorize where the A, the B, or each of these things are, but I will tell you what I do expect. This here and along the bottom are normal capnography, right? Normal end tidal waveform. The reason I bring this up is, even though I generally explain to people, like these glove boxes stood up, that end tidal are kind of just rectangles marching along, many times people will see this slight curve here and be like, oh, that's bronchospasm, that's a shark fin. And I'm like, no, the expiratory wave here takes a little longer. It always takes a little longer to get the air out than in, right?
In healthy patients, is it going to be very consistent like that, or is there a lot?
Yeah. No, I mean, there is variance, but because unlike an EKG, there's far less variance than an EKG. The more rectangular looking, essentially the better it is. This is perfect. Your expiratory phase is about twice as long as your inspiratory phase. That's is that how I want to phrase it? Sorry, reversed, essentially. I don't want to go too far on that, except for to say, sometimes people see this expiration wave here as this incline and are like, whoa, that's shark fin, because they're expecting exact rectangles, and it just isn't and shouldn't be. Where we'll start to see a problem is when that becomes far more pronounced than this. So we start here, essentially, the end tidal begins at the end of inspiration and the beginning here of exhalation as we go up. Of course, this ascending phase is us exhaling CO2. It's called phase 2. I don't care that you know that. This I do care that you know that this is the alveolar plateau. I don't necessarily care that you know it's number 3. The reason I care about this is for 2 reasons. That this is essentially where our alveoli are losing their CO2. It's the end of the phase. Where do you suppose, if you had to point a finger, where is end tidal, this 35, where is that measured at?
Right, peak right before it drops.
Yeah, right before it drops there at the D point, right? I think on the question I just have an arbitrary like 1, 2, 3, 4 or something, and I'm like, hey, where is end tidal measured? Just because I noticed that students often invert this in their head, where they view this like inhalation, and then the exhalation is shorter when it's actually the reverse. So then, of course, we've got our descending phase. It's a normal waveform, like we said. It's about 35 to 45, and it will be spread out at whatever rate is appropriate. Like if my patient is conscious and breathing, it'll be 12 to 20 for an adult, yeah? But there's all kinds of stuff. Let me ask here, essentially, we'll get a raised hand. How might your capnogram change if you intentionally start to breathe at a rate of 30? What do you suppose of the frequency?
The frequency would shorten.
So this is the amount of beats.
The beats would increase.
It would increase, if that's right. Duration?
Less.
Less. Why?
Okay, if you get a bus and you start grabbing people like CO2,
Sure.
but living faster, you get less people on it.
That's more about the saturation of the hemoglobin, but put pretty simply, your duration would have to decrease to fit the same amount of ventilations in the same amount of time. Like, because if you monitor how you're breathing right now, it's like, I'm like, cool, triple that. You're like, I'm like, okay, my duration is now decreasing. You have a question?
No, yeah.
Height?
It would shorten.
It would shorten. Why would, if I increase my rate to 30, would it shorten, go down?
Because you're breathing quicker and not as much necessarily.
Nice, gold star for him. Well done. Because you're breathing, the faster you breathe, essentially, the more end tidal you're going to get out, and then that's going to drop, right? What about the shape of it? Sebastian?
The plateau would be shorter.
Yeah, I think so. That's how I would refer to the duration, so I have no idea what it means here. I think it's to set up the further questions, but yeah, that's what I would...
And so it wouldn't necessarily make the fin.
No, and that's kind of my point, is that we're not going to see shape change until we're starting to get pathological obstruction issues. Like, you would be okay saying, I don't know anything about end tidal waveform except for this. It goes farther away from a rectangle and closer to a shark fin when you have bronchospasm or bronchoconstriction. And I would be like, great, that's the most important thing you need to know.
What about like too small respiration? What does that look like?
Fair play. This essentially could be Kussmaul, right? Not this waveform here, but a rate that's 30, what are you asking me? Be specific. Like, what would it look like?
Yeah.
It's just asking me, Kussmaul respirations is hyperventilation, in a sense. So it would be fast with a bunch jammed in over a short amount of time, and your end tidal would drop. Is a person who is in DKA acidic or alkalotic?
Acidic.
They are acidic. How is it possible that they're acidic if their end tidal is low?
Because they're breathing off all the CO2.
So what happens here is, if you only associate acidosis with end tidal, you might say, oh, well, this DKA guy, he's at 25 capnography, so he's probably, he's probably alkalotic. And it is like, no, he's definitely acidic. The lactic acid is building up so fast, right?
Because then that's a metabolic issue.
That's right. I don't have this question, but maybe this year, maybe next year, but every year I want to ask the question, which of the following is caused by DKA? And you would expect to see the answer, metabolic acidosis, but it's not on there. What is on there? Low end tidal, or more to the point, respiratory alkalosis. And you'd be like, diabetic acidosis causes, no, respiratory alkalosis is occurring because metabolic acidosis is happening. They're trying to balance. This essentially could be DKA. I hate the numbers here. I think they're oddly, try not to focus on the numbers of these things, more on the wave. I think they're implying some different things. Because essentially this is saying like normal end tidal upwards of 45, and so I guess this kind of works. You're less than 45 now, but the question I guess I would have is like, is this 25? I don't know what it's saying. So we would expect in hyperventilation your end tidal to go down. Now what about the reverse, right? Jack, what would be the frequency, the timing of your respirations if you're at 8? Mm-hmm.
They'll have more space between.
Is she right? Yeah, snap your fingers with me, right? Okay, now slow it down. Right? They're spacing out more. Yeah, so our frequency. So you could look across the room at a monitor and see a slow waveform and know you got a major issue, right? What would happen to your end tidal if you had a slow waveform?
Go up.
It would go up. But again, unless you count the fact that we're getting broad waveform here due to the necessity of trying to get that gas out on a slower rate, right? Again, I don't want to fixate too much on the shape of these things because quite frankly, I don't super care. I care more that you can determine the rate and that you know what bronchospasm looks like. Right? And so in this case, we've got what happens all the time, especially on certain monitors like a LifePak, I think 12, when you print it, it looks really drawn out and changes the way it kind of appears. The amount of times I've had people tell me that is shark fin, the orange one, is insane. Because I think people expect little marching rectangles. And they're like, look at the hook there on the front. I'm like, no, that's normal because it always takes a little while to kind of get all that CO2 out of your alveoli. This right here is implying that our exhalation is is longer. It's taking way more effort. Yeah.
So the alveolar plateau, that's always sort of slanted?
It's not always slanted, but it is slanted in both of these cases, it is slanted forward. Yeah. It just has to do with how it's really easy to get CO2 out of your trachea. It's much harder, essentially, to process it from down here, and that changes the speed at which it's expired. But again, the emphasis is on the shift here, the shark fin, right? Now, you traditionally heard me say that shark fin capnography is indicative of what condition? Bronchospasm, and that is true most of the time. Why would, Lauren, do you know why bronchospasm is changing the shape of our end tidal? That is true in a generic sense. Can you be more specific as to what kind of person would, if you saw this, what condition might you suspect? Okay. Don't know? Okay. What would I think, Landon? Asthma is our go-to. That essentially I'm associating this shape with bronchospasm. The question would be, can it be anything else? Yes, it can. What could it be? Yeah? COPD? Be more specific?
Bronchitis.
There you are, my man. Bronchitis.
It can be on the
So here's what this is showing us. This is showing us that I have a physical restriction of the bronchioles. Now, whether that's because they're spasming or because the interior lumen is clogged up with a mucus, in any case, this shark fin is implying that I'm having a restricted bronchiole, specifically. Pulmonary edema won't do this, because pulmonary edema, as much as it is interrupting the diffusion of oxygen, CO2 can travel pretty freely through it. It will not look like this because it's not restricting the movement of the CO2.
Why is it able to? It's just the different weights of the molecule.
Ooh, I do not know, my son. All I know essentially is that, that CO2 diffuses, like, I can't remember now. It's like 20 times easier than oxygen. It comes down to a level of chemicals, chemistry that I definitely don't know.
Okay.
Good.
So that like the shark fin is kind of just like wheezing just in general. Because you're
No.
breathing, no.
No, not specifically. Wheezing can be from a restriction of the lumen of the bronchioles, so like bronchospasm or a mucus plug, making it very tiny in there. But you could also have fluid in there that's making a wheeze sound that is not restricting CO2 movement, so it won't look that way.
But it's still constricting oxygen. Okay.
Yep. Oxygen has a hard time in pulmonary edema, whereas CO2 doesn't. So where this takes place is you see a guy that's having trouble breathing and somehow missed the fact that he was a congestive heart failure patient, I guess, basically. I mean, it does somewhat happen. I guess I shouldn't be so pointed, but what this means is you auscultate lungs and hear wheezing. You put them on end tidal and see this, it means bronchodilators. You listen to lungs and you hear wheezing and rhonchi and rales and all kinds of soup like you usually hear, and you put them on end tidal and don't see that, then it does not mean bronchodilators are going to help him. Yeah.
Would pneumonia also present with shark fin?
It can.
Okay.
Basically, before I taught you, that means bronchospasm. Give albuterol and Atrovent, which is a good way to start. Sometimes mucus will do that too, because CO2 does have a hard time getting through mucus. Now, you can't know which one it is really, so I'm going to go ahead and give albuterol and Atrovent as long as it looks like that. So there are essentially two things that I would give albuterol for. If a test question said your patient is wheezing, what should you do? Albuterol and Atrovent. If that's all the question said and all I had was wheezing, that's enough to get me to give albuterol and Atrovent. If it said your patient has wheezing and pulmonary edema, now I'm like, oh. I'm not so sure giving an adrenergic medication to a person with pulmonary edema is going to help him. Let's put him on end tidal to see if it's bronchospasm I'm hearing or if it's pulmonary edema that's causing the wheeze. Okay. Oh, that's great. See how it's printed and it just looks different? Waveform can tell us a bunch of different things. You can find giant charts. It's funny, I'll look at a chart of like all these different presentations of waveform and I'm like, cool, I've seen 3 of those in 15 years, So I would be a little careful here. This one perhaps should be obvious, but again, this comes down to what do I want you to do if you're bagging a person you just put an eye gel into and you start to see this happen?
Check the equipment.
Reassess, ABCs, look, listen, feel, right? Absolutely. Hypopharyngeal dislodgement essentially is talking about how it is unseated from its pharyngeal placement. So it's now, well, actually hypopharyngeal ET, below pharyngeal.
Well, but it's at the hypopharynx, it's like the laryngopharynx. It's the same thing. It's the lowest portion of the pharynx.
I don't know. What I'm sure is I just don't know how like if you can't push. Worst case, the farther you push an ET tube, it'll go into one lung, it'll go into a bronchi. So I guess maybe that's what they're implying. Yeah, I guess that's what they mean, is that essentially you've main stemmed the ET tube, I guess. But I would look at that and be like, oops, my tube has come out. That's what I would think. Now, if we're rocking an end tidal on a patient and it's whatever, whether it's 10 or 20 or 40, and we suddenly see a jump of 10 to 30 points or something, I don't have a test question that gives a specific number. But if I'm just watching them tick along in cardiac arrest and suddenly see that, what do I want you to do? Check a pulse. Why? What's happening here? Like, let's assume that your iGel was good, that your CPR was good, that everything you were doing is textbook, and then all of a sudden, this happens. What is this showing me?
Metabolism, cellular metabolism.
Right? It's showing me that there's end tidal coming out of his mouth. What is the end tidal measuring?
CO2.
CO2. Where is the CO2 coming from? Right? His mouth, his trachea, his lungs, his blood. His blood is going back to his tissues. What's happening in the tissue? Metabolism is happening, which means it must have had what and what? Oxygen and glucose. So then where did that oxygen come from? From the blood. The blood went back to the lungs. So now I have learned, because of sudden end tidal spike, it is implying that from start to finish, it's boomeranged all the way around. Yeah.
Does it often look that drastic, or does it kind of like generally increase?
Yeah, it's a couple of weird bumps and then a regular one.
Okay.
Usually I don't notice it immediately. I just happen to look over and see it at a much higher rate, and I'm like, woohoo! Okay. With decent compressions in most cardiac arrests, you should see around 20 or so. This can vary wildly based on what killed the patient, how soon you've arrived after they've died. So don't use it as a hard and fast number, but I could see the AHA saying something like your patient, they probably won't give a number, but if they did, they might say something like, oh, you were rocking a cardiac arrest at 30, end tidal of 30, and now it's 15, what should you do? And the answer is going to be what? I can appreciate that, but that's not the first answer. It's a correct thought, but it's just not the first answer. That is half of the equation. Ventilation. What's the other half? Perfusion. Say it again. Check compressions. Right? So you see a decline in end tidal, immediately I'm looking at the guy's chest, just like I would if it goes to 0, right? Look, listen, and feel. If he's not getting good compressions, if he's not getting good chest rise and fall, then I need to change things. Change the rate, change the depth, whatever's going on, right? A sudden increase, 8 or more, I keep throwing these numbers all around, but mostly I just mean you watch a spike go up. I don't think you necessarily need to know this, but this is what's called a curare cleft, which is probably the only other thing, but this is really more for medics, just simply. This is sedated patients that you have end tidal on when they start bucking the tube, right? If I give you essentially some paralytics, knock your respiratory drive out, and I take your airway away from you, and I keep ventilating you, it should look like clean ventilations. And if suddenly I start seeing these little jaunts in it, that's called a curare cleft, and it means your patient's coming back. It means they're starting to gain control of their own respiratory drive, and it probably means they need more good night juice, or else they're going to start choking on the tube you put into them. I mention it to you because as an AEMT, you might be working with medics, and if you start to see that happening, you're like, hey buddy, let's give that guy some more paralytic, please. I don't know how Mr. Dennert teaches it, but you'll learn later about succinylcholine and which one is a polarizing and non-depolarizing. Essentially, if I put an AED on your hand or your arm and I shock you, it will close your hand because it's depolarizing those muscles. If you have a closed hand and it shocks you, it will open them. So it's depending, right? So you have some paralytics that will cause a depolarization, and you have some paralytics that are non-depolarizing, meaning they don't depolarize the cells. I always remembered it as succinylcholine depolarizes because you sucked a pole. So that's a freebie for medic class. Now we can also use end tidal in the presence of herniation. I want to move quickly through this so we got time for some of the other things. Basically, we have to look for, if you got a head injury patient, if I've got anisocoria, posturing, or just a sudden rapid neurodecline, I get a guy that gets ejected from his vehicle. He's got a hematoma on the head. He was talking to me and now he can't. I'm suspecting he's got brain herniation. He's shutting off, right? When we suspect brain herniation, not just he got hit in the head with a hammer and his vitals are fine and his pupils are okay. I mean, when we're suspecting that his brain is, his skull is filling with blood and it's forcing his brain down into his magnum foramen and putting pressure on his brain stem. When I suspect active herniation, we are not going to hyperventilate, even though the book will say that. We are targeting 30 to 35, which in my opinion isn't hyperventilation, it's targeting a specific end tidal. When we lower CO2 causes vasodilation. CO2 of 50, vasodilation. CO2 of 20, less dilation. So when I get more CO2 out, it forces these cerebral arteries to constrict and therefore restrict the amount of blood that's filling up the skull. So all of that to say that if you got a guy with a suspected head injury who has posturing, which is the lowest totem of the neurological possibilities, or just this sudden shift after a head injury, then my guy who's ventilating, and I've told him, hey, just ventilate this guy 35 to 45. And if I start to see these weird changes, I'm like, change of plans, buddy, take it below 35, but not below 30. Just keep it just below 35. Did I miss a question in there? Yep.
So wouldn't anisocoria be a pretty late sign too?
Again, I mean, yes, but the question would be chronologically late or just late in the curve. So, I mean, if I had a big enough bleed, it might happen fast. Does that make sense?
What was the correlation with the high CO2 and vasodilation, or what was it?
Sure. You've got a guy with a suspected brain herniation. Do you want his end tidal to be higher or lower?
Lower.
Lower, because high end tidal causes vasodilation. So if his issue is a hemorrhaging brain, I want to constrict those vessels to restrict the amount of blood that's filling up his skull. In summary, mostly what I'm not going to ask you about vasoconstriction and dilation. I'm going to paint a picture like a guy where you're like, that dude has got a brain hernia, and you got to know that suddenly you need to target end tidal of 30 to 35. Which I have to be honest, I almost don't want to teach 30 to 35 because there's also studies that talk about when you get below 30, it's catastrophic. I mostly just want to say, hey, keep it just under 35. Target 34 is probably a better thing. Cool. I'm not going to take a quick break here just because we've got about 19 minutes, but let me show you. We'll spend 19 minutes going through this next part. I think it's how you should go through chapter 17 because end tidal is it's a portion of the test. It's not the entirety of the test, even though it was the entirety of the lecture. So basically what I want you to do right now is I just want you to spend some time thinking about what causes one, what the CO2 level might be, what your blood pH might be, and some specific signs and symptoms that would be indicative of one or the other thing. Now, I don't care how you slice it, you're one, you're the other, right? So Destiny's hyperventilation, you start thinking about that one. Kendall, your Kussmaul respirations. So take a few minutes, think about it, write it down, and we want to figure out what these are as a group, right? Pow, 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 Jack. What do you think?
What do you mean by
What's causing hyperventilation? Your patient's hyperventilating. What could be a cause? Say it again. Anxiety, sure. It could be a psychological deficit. Yep. And obviously I'm contrasting from Kussmaul, so even if you said, well, hyperglycemia, I'd say, we'd probably see that more over here than there, right? Yeah, because I wouldn't call necessarily, you might walk in and be like, whoa, he's hyperventilating. Oof, fruity breath, that's Kussmaul, it's not hyperventilation. Okay, what would you think of the CO2 level in hyperventilation? So it would be high or low? If it would be low, that's okay, right? Because if this has got a bunch of Monster in it and I pour your Monster out, it now has less Monster in it, yeah? Okay, so then what do you suppose would happen to the pH of a person who's hyperventilating?
Probably try and go up. Take time.
Yeah, it would go up, right? Because they're becoming respiratory alkalosis, probably. Well, I don't know how the pH shifts, how fast it shifts, but I know they'll find effects almost immediately. And that leads us to our next thing. What would you suspect a person with respiratory alkalosis, a sign and symptom?
I'm not good at that part, but I know what you
That's
mean.
okay.
I
No, not necessarily. Let's take it back. Let's do it simpler, okay? You and I are working together. We get a call for a 16-year-old girl who is having a panic attack. We show up. She's hyperventilating. What else is happening to her? You ever run a call like that? Maybe pass out. There you go. Which is what's happening in respiratory alkalosis or carpal tunnel spasms. What up? Early.
Early? Okay.
I love that question, though. Good job, Bruce.
Well, maybe.
All right, let me interrupt you so we can kind of move on just because we're pressed for time. All right, Sam, cause of hyperventilation? I should have made this a Family Feud or something. Like, ding, how many people? Anxiety, but yeah, okay, we'll accept it, right? Sabina, Kussmaul respirations cause? DKA. CO2 levels, Alanis, for hyperventilation. Low, any thoughts on that? Any difference of opinion? Very low, absolutely. What about Pam, Kussmaul respirations, CO2 levels? Huh? Say it again. It would increase? Okay. Show me what Kussmaul respirations look like. Do it where everybody laughs at you. Well, a million people whispered to you. Now I have no idea what. Okay. Great job, I think. I don't know. Essentially, right? If I'm breathing fast, it's coming out, right? Even though they are both low CO2 levels, the pH is different. Why, Aiden, why is the pH, even though I'm breathing off my CO2, which turns into carbonic acid, why am I essentially becoming acidic?
The ketones are acidic.
Because the ketones themselves are acidic. Similarly to shock, right, and lactic acid building up, despite the CO2 levels.
So with the CO2 level for the Kussmaul, could it not still be high? Because
No.
you're breathing out.
Yep.
But isn't it like ineffective?
No, it's pretty effective.
Even yours impact. Your peak.
Okay. That's interesting. I just feel like that's your body like trying to compensate.
Yes.
But is it not working?
Correct. The reason is because even though it can quickly adjust CO2 levels by just pulling the hatch, making you breathe faster or whatever, the problem is the ketones are like, let's just make up a number, 10 times more acidic than the CO2. It can't keep up.
Gotcha.
It's helping for sure, but it's not keeping up. Oops, also answer. Yeah.
I put tingling.
Yeah, which is paresthesia. Right? Paresthesia, not to be confused with palegia or paralysis. Why diabetes 1 with DKA?
Because they aren't able to produce it.
Yeah, sure, Sebastian.
Because it's like an insulin. They're not making insulin.
Right? I guess more to the point is why in something like HHS or HHNK are we less inclined to get Kussmauls? Yeah.
Because there's still insulin there, but it's just heavily resistant to it.
That's right. In diabetes 2, the cell, it's not that there's a lack an absence of insulin. In fact, it's many times or oftentimes the opposite of that. You have, by your lifestyle choices, in many cases, subjected yourself to a lot of sugar, so your body subjects yourself to a lot of insulin, so therefore your cells and all of the volume starts to decrease. Cool. Let's do it again. This time you go with her, I'll go with Aiden.
Which one do I have?
Why don't you start with asthma?
Okay. Asthma, lower airway, bronchi, bronchioles. What? Bronchospasm.
Love it.
Why? It's a hypersensitivity, causing the smooth muscles to constrict.
Love it.
Wheezing could be diminished or absent if it's severe. Sometimes wheezing. If it's a kid, signs of respiratory distress is kind of what I'm looking for. Untitled will be decreased. And it'll be shark fin, but it'll be decreased because it's a obstruction on the way out.
I don't remember. I think that I could make so many of these, I feel like I could make a case either way.
Yeah.
You know, I would be, because in my mind I'm thinking like, okay, I have constricted bronchioles, therefore I have CO2 trapping.
Yeah.
But when you're with an asthma patient, they're going to be hyperventilating to compensate for that. So my question is less, what's the EtCO2 and more, where are we at in the timeline? Because initially, it's going to go up.
Yeah.
And
if you
then-
give them a bronchodilator, it'll probably go up.
Yeah, because it's just going to come out in
Right.
spades. Yeah. But if it doesn't get fixed, well, then sure, they all end in zero eventually.
Right.
Yeah.
All right, bronchiolitis, bronchioles. What? It's a viral infection.
Yeah.
Why?
Do you remember which one often? It's the only one I know.
RSV?
Yes, well done. Yep.
Why? It's RSV.
Yeah.
It's like our grandparents kissed you or something.
I don't know.
And you were 2 years old or 1 year old or whatever. Lung sounds.
Love hurts.
Wheezing.
Yep.
Key signs and symptoms: fever, wheezing, being 2 years old.
Yeah. Less than.
Yeah.
Yep.
And title depends, I guess.
Yeah.
But it probably, I would think that because they're febrile, they're in more demand.
Just higher by
That'd be a
nature.
high- yeah, what was
Makes
it?
sense to me.
Hyper. What was the word?
Metabolic.
Yeah, hypermetabolic state.
Yeah.
Wave form, shark fin.
Yeah, maybe. Yeah, cool. Very cool. All right. Alex, what do you think about asthma? Where's it at? Say it again? Yeah, bronchioles, more to the point, but bronchi as well, it can be, for sure. What about Sabina, bronchiolitis?
I put the bronchioles.
I put that too. Sam, what is asthma? Bronchospasm. I like it. Anything else? I know it's a little ambiguous in the beginning, not really sure what I'm looking for. You'll see all kinds of this stuff pop up, right? Bronchospasm, less airflow. Sebastian, what about bronchiolitis?
It's like a infection
Yeah.
for like infants.
Yeah, we're starting to get inflammation, which isn't always the case with asthma, though it can be. You can have secretions in asthma. It's a reactive airway, sure, for sure. But we're going to see more mucus production here in bronchiolitis, also just general inflammatory processes for sure. Let's see. Tati, for why asthma?
I don't understand what you mean by like why.
Yeah, my sister has asthma. Why?
Because like bronchoconstriction, like
That's what it is.
trying to like.
Yeah,
Allergy, like it's a lower airway.
kind of. Yeah, kind of. Landon?
Because it's a reactive airway disease.
Asthma is just the name we give to people whose airways essentially overreact to stimulus and stuff. Let's say the majority of people in here don't have asthma. They can handle dust mites just fine. It's not great, but it doesn't cause an issue. But let's say, Chris up here, Chris has a condition where a dust mite gets in there and his airway traps down. And we're like, right, we need a name for that. And since peanut butter and jelly is already taken, we'll call it asthma.
So it's just like a hypersensitivity?
Yep, it's a hypersensitivity. It probably involves some type of IgE. I definitely don't know anything about. Viral infections are what usually causing bronchiolitis, and specifically RSV. If I see RSV in a test question, I'm looking for the bronchiolitis answer in a hurry, for sure.
Is there a few that can cause RSV?
There are, I just don't know them. Lung sounds destiny for asthma. Okay, could it be anything else? What could it be? What up? We'll do one more, then we'll take a break, and then. Could it be anything other than wheezing?
So bad.
It will not cause stridor.
Maybe absent. Like something.
It could be absent. Very good. Why would a person whose bronchioles completely closed? Amazing. Well done. Absolutely,
What about
Sebastian.
like crackles? Wouldn't there be like, couldn't there be secretion?
Absolutely. If you said, do I expect to hear crackles in asthma attack? I would say no. Can you get secretions in there? Sure. And inflammation and these kinds, sure. But generally speaking, there's a slide we use in EMT where it's like, here's what you need to remember. Asthma, bronchospasm, wheeze, cardiogenic shock or CHF, pulmonary edema. Everybody got those lined up all the way down? Great. And then the next slide is all the arrows going everywhere. And I'm like, they can kind of all cause, I mean, if you think about it, all pathological airway conditions lead to absent lung sounds eventually. There is similarity there on a longer timeline, right? All right, let's do one more. Let's try here, okay? So we'll just split off. Let's see, Mr. Denner, you'll be with Aiden.
Yay.
And so, you know, just listen to him go down one and then go down the other. Yay!
It's not just us. Everybody else is doing it.
No, everybody's gonna watch you. All right, I'm gonna interrupt you there for time. Let's start to kind of walk through some of this stuff. Let's see, I don't even know. Lauren, where for pneumonia? You're just like, oh, he hasn't called on me, or does she just struggle with the where of? I'm trying to keep track of who people sneak through, like Jack and Shannon, right? Largely in the alveoli, the parenchyma. Does anybody remember what the distinction of parenchyma is? Part of the emphasis I want to make on this, if we kind of scroll down through it, is that pneumonia is not, I think it's often just, people would say, oh, well, right, with pneumonia you can get rhonchi and you know, a lot of mucus builds up. And I'm like, okay, mucus can happen, but mucus would largely be a byproduct of the bronchioles. Pus is a very different thing. It's a sign essentially that we've got a major infection happening and that we've got white cells building and destruction of cells. It's a profound problem. More to the point is that I guess what I'm trying to get across here is we're talking about destruction of your respiratory tract in general, and more to the point also alveoli, which is why like those homework questions when we talk about different conditions, are they ventilation and perfusion issues, sometimes they'll overlap on a long enough timeline, because in something like pneumonia, where, yeah, it's largely respiratory, also you'll start to get destruction of those alveoli that is now having issues with perfusion and ventilation. And so even those questions for me on the homework, you know, as I look through each person's thing and they're like, oh, I think this, I'm like, I can make a case for that, I think. I can make a case for that, right? So one of the issues that I want to make here is as we fill up this, like I said, as we go into preparing for test 2, would we have all day, we would go through every single condition like this, and I would just be like, okay, what's like the one thing that, what's the word you could say about this condition that gets me in that wheelhouse of thinking it in the first place? Your guy has a respiratory condition and he has an infection, you know? And you're like, oh, okay, yeah, well, the bronchiolitis and pneumonia, but definitely not asthma, definitely not other things. And that's kind of how we need to go through it. And so I just wanted to show you a couple of here. Shannon, what's the why of pulmonary edema? Sure, where's the fluid coming from? Yeah, absolutely. Heart is a number one thing. Drowning will do it for sure, right? There's a myriad of different things there. ARDS and non-cardiogenic issues essentially causing the same thing. You know, like I said before, I don't know that I need, that I don't have test questions that's like pneumonia. Is it a diffusion or ventilation problem? More I'm like, they're dying because they can't breathe. Do you see that? Do you see that? Do you know how to fix it? But it's worth distinguishing certain things like here. Why would a person have a ventilation issue more in pneumonia perhaps than in pulmonary edema where we describe it as diffusion? Because what is, if I said what is ventilation, could we break that down?
Physical
Of? Okay, be more specific than air. Oxygen and? CO2, those are big ones. Nitrogen takes up a lot. In a case where we've got pus filling up our alveoli and confounding our bronchioles, are we having oxygen and CO2 troubles getting by? Definitely, pus is not great for conducting that.
just take way more effort to breathe with all that.
It does, for a myriad of reasons, for sure. Why am I making a distinction here to say oxygenation and diffusion over just generic ventilation for pulmonary edema? Oh, do you got it, Henry?
Because of the interstitial space and like how diffusion would like cross the interstitial space, whereas.
Yes, but that's generically what I'm trying to get at. Tati, you got it?
Is it because, like, for pulmonary edema, with it being
Oof, can I follow you down there? I don't think that's exactly what we're talking. It's not what the point I'm trying to make. Landon?
With pulmonary edema, the CO2 can diffuse through the fluid way easier than oxygen.
There you go. I mean, I don't mean to say that you're not have ventilatory problems, because of course oxygenation is an issue because the oxygen can't be ventilated in appropriately, but CO2 will largely go out, which is why if we come down to waveform and we just kind of skip ahead, what do I expect to see in a waveform for something with pulmonary edema? It's a bit, say it again? Okay, you did a great job. I led into that like I expected bronchoconstriction, but yeah, fantastic. We might see a more normal waveform. Now, part of the thing where this kind of example breaks down, sorry, 33, brother, I'm sorry. Let me finish the point though. Yeah. Part of where this breaks down is it depends on the timeline that you're looking at it. And a lot of this is kind of built into the assumption that you're looking at it as it's starting to become a problem, but of course all these things will lead to zero. Now, this thing doesn't include everything. It's some kind of, I'm happy to share this now that we've played with it a bit, but it's somehow an amalgamation of both concise information and too much all at the same time. What would be best for you is if you essentially create your own sheet for a lot of these things, go to the book and try to figure that out, because a third of that test coming is going to be like, your patient looks like this, is like this, vitals like that, what do you think it is? Pneumonia, asthma, blah, blah, and then they'll have a follow-up question. It'll say, okay, your patient looks like this, feels like this, vitals like that. You have to know what it is, so that way when I ask, what should you do, then you know how to treat it. Yes. They aren't yet. It's part of the issue. I didn't want to share it ahead of time, or else I'd be like, whoa, you're getting the answer right to every one of these in the exact way you found it on Blackboard, didn't you? Okay, I'm just generically pointing to somebody. Definitely not Destiny. Okay, absolutely. So I don't mind it's on there now. I just have to unhide it, and I will definitely remember. So don't worry about it. And there's a few things like holes. Like I heard Mr. Dennert talking about consolidation with pneumonia, which I didn't even consider to put on there. I don't hit egophony too hard. I mentioned it in EMT class, but the idea is essentially that you can listen to lung sounds and ordinarily make an E, you say E, and it will change the sound of it from the consolidation of the pus. But so these things essentially shouldn't be looked at like comprehensive necessarily. But when you see it pulled up, you'll see a lot of slides that are hidden here. Basically, the idea is that if we had 6 hours to do this, it would just be a series of blank things like this. And then if people had questions about a topic, you can go to those slides and it'll give a ton of information. But at the end of the day, you creating your own Rolodex is going to be your way through it. So